Hello dear students, today we will talk about fissure sealing. Let's recall the stages of enamel histogenesis. The first and second stages of enamelogenesis occur during the formation of the dental follicle, and the third stage occurs after the eruption of the tooth. This stage is called tertiary mineralization or enamel maturation. At the time of eruption, the mineralization of the teeth is not complete. Tertiary mineralization of fissures continues for another 4 to 5 years, most actively in the first year after eruption. The degree of caries activity correlates with the initial level of enamel mineralization. In the beginning, I would like to talk about the types of fissures and their classification. There are 4 types: V-type, U-type, I-type, and IK-type. The most frequent type is the V-type fissure. Understanding fissure types is crucial for effective sealing. V-type fissures are most common. We have another classification of fissures: open and closed. Open fissures with good mineralization are less risky. Closed fissures, especially early after eruption, need sealing to prevent caries. In this photo are deep closed mature fissures. It is important that not all narrow dark fissures lead to need sealing. Usually they are mature, normal fissures, but some have pigment. There are many types for diagnosing of condition of fissures. First, visual inspection and probing is subjective and aggressive method. Immature and demineralized enamel can be damaged during examination. The second type of diagnosis is coloration with a special rinse. Such means are used to determine demineralized enamel. By combining with denaturate collagen, the composition stains the tooth tissue. For example, eosine, acid fuchsin, and methylene blue can be used. The main problem with this method is that weakly mineralized immature enamel can also be stained. This leads to overdiagnosis of caries. The third type of diagnosis is DiagnoChem, digital imaging fiber optic transillumination. This system is based on transillumination laser radiation generated by the device in non-X-ray wavelength range. DiagnoChem uses light instead of X-rays, eliminating radiation exposure, which is particularly beneficial for children and those concerned about radiation. It can help identify early-stage caries lesions, including those in the enamel and early dentin involvement, potentially allowing for remineralization treatments. The DiagnoDent is a laser fluorescence device. Healthy tooth structure and caries lesions fluoresce differently, and the device measures the intensity of the fluorescence. It can be a helpful tool in fissure sealing by aiding the detection of hidden caries, especially around or beneath sealants. While DiagnoDent is a valuable tool, it's not a standalone diagnostic method and should be used in conjunction with other techniques like visual inspection and radiography. Higher readings indicate more decay. X-ray methods such as periapical, Bitewin, and panoramic radiography. X-rays are better suited for detecting deep or hidden caries. Electrometry of enamel. This method shows that fully mineralized enamel does not conduct electric current. Thus, if the mineralization is weak, the enamel conducts electric current. The technique was developed in the USSR in the 70s of the last century at the Omsk Medical Institute. Now the Ortic ECD device is produced by Ortic Therapeutics Inc., USA. To conduct diagnostics, the steel tip of the ECD is placed in the fissures of the molars and premolars. The stronger the demineralization, the more enamel fluid gets into the damaged area. Accordingly, the more fluid is detected, the higher the current, and within the digital caries indicator on the device screen. Let me repeat once again. Healthy tooth enamel without damage is a good insulator that does not conduct electricity. Do not confuse electrodontometry, which evaluates the exactability of the pulp, with electrometry, which evaluates the conductivity of current in the enamel. I have already talked about anatomical classification of fissures. Now let's look at the different types of fissure conditions. The condition changes over time. Immature fissures become mature, and healthy fissures can also develop caries over time. First type is intact fissure with immature enamel. Such immature fissures also differ in the level of mineralization. I'll talk about this in more detail a little later. The second type is intact fissure with mature enamel. Some doctors believe that such fissures do not need to be sealed because the maturation of the enamel is complete. Other doctors believe that sealing can prevent caries in high-risk situations, such as xerostomia, and the demineralized fissure are pre-eruptive resorption at first and caries of enamel dentin. We will study this in the course of cariosology. So, intact fissures with immature enamel have different level of mineralization. For us, this is a very important indicator. The choice of tactics depends on the initial level of mineralization, whether or not to seal the fissures of children's teeth. This indicator was introduced into practice by the Soviet and Russian professor Larisa Kiselnikova. She actively introduced sealing as a method of preventing caries in children in Russia. Larisa Kiselnikova is currently the head of the Department of Pediatric Dentistry at the main Russian dental university, Rosunimed. Look at these pictures. Compare chalk, quartz, and diamond. These are stones of different strength and hardness. The same can be said about different levels of fissure mineralization. High initial levels of mineralization, clinical signs: the enamel is dense, smooth, shiny, the probe slides over the enamel, high caries resistance. Medium initial levels of mineralization. Clinical signs: some fissures have a chalky color, the probe is retained in them. The prevalence of caries in such teeth by the end of the maturation period is 60–80%. Low initial levels of mineralization. Clinical signs: the enamel is devoid of natural shine, the fissures are chalky, it is possible to extract softened enamel with a probe. Caries in such fissures develops very quickly, within 1 to 2 years, especially with poor oral hygiene. I will note that glass ionomer cements and flowable composites are used to seal such fissures, but not composite sealants. Look at these photos. In mature fissures, highly mineralized formations are found, heterogeneous in their structure, centrifugal currents of enamel fluid coming from adjacent tubercles and folds, and concentrated at one point. Natural mineral sealing of fissures occurs mainly due to enamel fluid. These fissures do not need sealing. In the bottom photo, we see self-sealing of the molar fissures, but there is a caries on the proximal surface. Demineralized fissures, caries, pre-eruption resorption, these are conditions that already require treatment, not sealing. In the photo, you see premolars with soft, demineralized enamel in the fissures. This is caries. On the radiographs of the cavity in an erupted teeth. These teeth will erupt with large defects. The molar is in the eruption stage, but there is already a large cavity in the dentin. Let's summarize the goal of fissure sealing. Provides a physical barrier to dental plaque, prevent oral bacterial and their nutrients from collecting within the pit of fissure. Modified tooth anatomy makes the occlusal pit and fissure easier to clean by toothbrush and mastication. Created smooth margins and the junction of enamel surface. Indications for sealing fissures. First, deep and closed fissures. Second, intact fissures with medium and low initial mineralization. Fissures with a high initial level of mineralization, open, shallow, fissure do not need to be sealed. The short period after eruption, no more than a year, but there are discussions on this matter. Some believe that it is possible to seal fissures later. The question is, what to do if more than a year has passed since the tooth eruption? It is necessary to look at the clinical situation. If the caries activity is high, preventive fissure sealing can be performed. Contraindications to sealing fissures are: first, open when cleaned fissures. I've already mentioned this. Second, pits and fissures that remain intact for 4 years after eruption. Third, enamel and dentin cavities. Caries should be treated with fillings. And fourth, poor oral hygiene. Sealing will not be successful. The sealant will probably be lost. At what age are different teeth usually sealed? 2–3 years old, temporary molars. 6–7 years old, first permanent molars, lateral incisors. 9–10 years old, premolars. And 11 and 12 years old, second permanent molars. This method of prevention has its supporters and opponents. You should also know the arguments of opponents of fissure sealing. Sealing disrupts the natural mineralization of fissures. Saliva does not penetrate into the closed area. But mineralization occurs along the sealant enamel border, and caries does not develop in obturated fissures. Sealing disrupts the occlusal relationship between the antagonists by smoothing the surface relief. But if the procedure is performed correctly, the sealant remains only in the depth of fissures. Sealing is ineffective and promotes the development of caries if the sealant is poorly fixed, chips along the border, and falls out. It is important that the correct sealing technique can minimize this risk. And now let's talk about different sealing techniques: non-invasive sealing and invasive sealing. What is the difference? The difference is in fissure preparation. In 1971, the first dental sealant, NuvaSeal, was introduced. And since that time, many studies have examined various products' ability to seal the occlusal surfaces of teeth to maximize prevention. Sealants have only mechanical retention to enamel, so the enamel is etched before sealing. Criteria for choosing a sealing technique: initial level of enamel mineralization. The most common is the medium level. Degree of patient cooperation, especially when sealing primary and first permanent molars. Status and location of eruption. Partially erupted molars are difficult to seal. Time since eruption. Some researchers believe that it is necessary to wait several months until the tooth intensively mineralizes from saliva, while other doctors seal teeth as soon as possible after eruption. Quality of insulation. If the tooth is not fully erupted and you cannot isolate the chewing surface well, mechanical retention will be poor. The predominant types of sealing materials currently used are resin-based sealants and glass ionomer cement-based sealants. Resin-based sealants are classified into 4 generations, determined by the method of polymerization. The 4th generation is a fluoride-releasing resin-based sealants. They are products resulting from adding fluoride-releasing particles in an attempt to inhibit caries. According to the literature, however, fluoride resin-based sealants cannot be considered as fluoride reservoirs, providing a long-term release of fluoride. On this slide, you see examples of composite sealants. Then can be filled or unfilled, transparent or opaque. When using opaque sealants, it is easier to see chips or material loss. On this slide, you see examples of flowable composites. Composites are used in adhesive technology for invasive sealing with low initial level of enamel mineralization. A very important property is good material flowability. Compomers, a hybrid of glass ionomers and composites, are also used for sealing. You can see examples on this slide. They combine the aesthetics, strength, and good adhesion of composites with the release of fluoride and biocompatibility of glass ionomers. And the glass ionomer cement for sealing. Glass ionomer cements chemically bond to the enamel, providing the better seal than some other materials such as sealants. They contain fluorides, which are gradually released into the surrounding enamel. Glass ionomer cements can be used even when teeth have not fully erupted or in condition of sufficient insulation and dryness. And now I will tell you about the sealing method. First, non-invasive sealing, which is used on teeth with a medium initial level of mineralization. This is the most common option. The method is simple and fast. Remove the plaque, cleanse the pits and fissures, evaluate the surface to be sealed, isolate the tooth with a cofferdam or cotton rolls, acid etch for 10-15 seconds, rinse with water, dry the tooth, apply the sealants to avoid air bubbles, light cure, evaluate sealant coverage, check occlusion and contacts, remove excess sealant. The last step is applied to fluoride. A very important step is to clean the fissures well. You can clean them with a round brush and paste as well as an air-abrasive device. You can use glycine powder, sodium bicarbonate, tricolores. Acid etch, this is a crucial step in the bonding process. Apply a very thin coat of sealant material with a small brush or a syringe. You can use a probe to help the sealant flow into fissures. Avoid oversealing. Avoid air bubbles. Leave in place for about 10 seconds before curing. Next technique is invasive sealing. So what is the difference between invasive sealing and non-invasive sealing? The key word is invasive. We disrupt the structure of the tooth when we grind open fissure. This technique uses flowable filling materials. In fact, this is already a mini filling. You may also hear the term preventive filling, which is the same thing. Of course, it is a more difficult procedure. The stages are: remove plaque, clean pits and fissures, grind fissures, isolate the tooth, etch with acid for 10-15 seconds, rinse with water, dry the tooth, first apply adhesive or primer, distribute material with probe, light cure. Then apply composite material or glass ionomer cement, light cure, check occlusion and contacts, remove excess sealant, apply fluoride. Following the algorithm is the key to success. For micro preparation or grinding of fissures, special burrs are used, fissurotomy. The design of this burrs has been developed specifically for the gentle preparation of dental tissues. You can also use an ultrasonic tip or abrasive treatment with aluminum oxide powder. So we have considered the remaining stages except for bonding. There is nothing complicated. Apply a thin layer of adhesive or primer for glass ionomer with microbrush, air thin for 3 seconds and light cure. Another piece of advice, try to avoid excess material to minimize polishing. Use a fine polishing cup or rubber point and gently polish. This slide shows the results of an interesting study conducted in 2020 at the Faculty of Dentistry, Istanbul University. The study assessed the condition of 322 first molars after sealing. The conclusion was that dental sealants can slow down the progression of caries, effectively stopping and reversing non-lesion caries. Although their effectiveness peaks in the first 2 years, sealants can provide protection for several years, with some studies showing full retention after 5 years. And in conclusion of the lecture is summary of modern sealing concept. First one, sealing is effective in 50–90% of cases while maintaining the integrity of the sealant. Second, with proper application, the service life of sealant can be up to 15 years. And third one, approximately 2–4% of sealants need correction after the tooth erupts completely. Dear students, thank you for your attention. Remember that prevention is always better than cure.